Hello everyone, this is Dr. Hashem Abu Serhan. I am today presenting a meta-analysis paper, one of my meta-analysis papers, about the effect of intravenous mannitol on intraocular pressure changes in vitrectomized and non-vitrectomized eyes, a systematic review and meta-analysis. I don't have any disclosures to declare. So this paper was published in the American Journal of Ophthalmology, one of the best ophthalmology journals, with the Q1 quartile index. This is the title of the paper, and it was published again in the American Journal of Ophthalmology, and I was pleased to be the first author of this paper, and it was published online in July 2024. So as a background, mannitol is an osmotic diuretic that works mainly on the proximal convoluted tubule with the descending limb of lobe of Henle by increasing the fluid osmolarity. So it draws the water from the different compartments, leading to decreased intraocular pressure or decreased intracranial pressure. That's why the main use of mannitol is due to elevated intracranial pressure or elevated intraocular pressure. So in this paper we are questioning the common belief between eye surgeons and ophthalmologists that mannitol only works by vitreous shrinkage through increasing the plasma osmolarity and drawing the water from the vitreous cavity toward the bloodstream, causing vitreous dehydration and thus therefore reducing the IOP. What we are questioning, is this the only pathophysiology or the only mechanism for the IOP reduction effect after giving mannitol? Any other reported mechanism in the literature? Yes, there is one of the papers published in Glaucoma Journal 2021 talked about central mechanism effect from the mannitol, that mannitol affect the osmoreceptors in the hypothalamus, which also contribute to decrease aqueous humor production. Okay. In addition, this very nice paper published in the Indian Journal of Ophthalmology just recently, 2023, Dr. Sahu and his colleagues evaluated different ocular parameters like IOP, central corneal thickness, anterior chamber depth, lens thickness, axial length, vitreous chamber depth, after administration of mannitol in both the groups, vitrectomized and non-vitrectomized eyes. And if we see in this table that both the axial length and vitreous cavity depth decrease significantly in both vitrectomized eyes and non-vitrectomized eyes. Also, we see that anterior chamber depth decreased in the vitrectomized eyes and increased from 3.34 to 3.36 in non-vitrectomized eyes. However, this change was statistically insignificant in both groups. However, the axial length and the vitreous chamber depth decrease in both groups, and this was statistically significant. So they conclude that the main conclusion of this paper that both mechanisms, the direct osmotic effect from drawing water from the vitreous cavity and the central mechanism by decreasing aqueous production, play a role in the IOP reduction effect after giving mannitol, because the vitreous chamber depth decreased even in vitrectomized eyes, and the anterior chamber depth increased even in non-vitrectomized eyes. So both mechanisms work together. So the knowledge gap that we are addressing in this paper, is mannitol effective in reducing IOP and vitrectomized globes, which is common scenario in the ED, that patients with a history of vitrectomy surgery or retinal surgery, silicone all filled eye, coming to the emergency, presenting with high intraocular pressure. Now the common question is whether to give mannitol or not. So this paper addressing this knowledge gap, that we are aiming to prove that mannitol can also reduce the IUB in vitrectomized globes as non-vitrectomized eyes. So the methodology of this paper, as the most methodology of systematic review and meta-analysis, we follow the PRISMA guidelines. Our protocol was registered in Press Bureau, and we searched for databases, PubMed, Scopus, and Web of Science, and we included all primary studies like randomized clinical trials, cohort, and case control studies that reported vitrectomized and non-vitrectomized eyes with high IUB treated with mannitol, and the primary outcome is the IUB change following the mannitol administration. Two independent reviewers screened the title and abstract. This is the first screen, followed by the second screen, which is full text screening, and two also independent reviewers extracted the data about different data like study baseline characteristics, study design, sample size, and also participant characteristics, also the intervention details, the dose and the concentration of the mannitol and the frequency, and the follow-up period, also the outcome measures like the IUB reduction effect. Also the risk of bias was assessed by the Robbins 1 tool, which is very common risk of bias assessment tool, belongs to Cochrane. We did a meta-analysis to aggregate the results of IUB change from the baseline after the treatment, and also we assessed the heterogeneity in our results by presenting the I-square results. If the I-square results were from 25% to 49%, this indicates low risk of bias, and 50 to 74% indicates moderate risk of bias, and above 75% indicates high risk of bias or high risk of heterogeneity. And we also statistical significance level was set as p-value less than 0.05, and we did all the meta-analysis in using our software. So a total of 5 studies were included after 1,458 studies evaluated from different databases. We ended up with total 5 studies. These 5 studies, 3 of them were conducted in India, 1 in China and 1 in Pakistan. 4 of them were prospective comparative study, only 1 was retrospective case control. All of the studies used 20% mannitol, 1 milligram per kg. 3 studies included both vitrectomized and non-vitrectomized eyes, while 2 studies only evaluated vitrectomized eyes with silicone oil or gas tamponade. And all studies, the main result that all studies reported a beneficial effect of mannitol after reduction of IUB. So this is the baseline characteristic tables. As we see, these 5 studies, and the key result that IUB statistically significant mannitol reduces IUB significantly in both groups, vitrectomized and non-vitrectomized group. Even that in Takar study 2017, they reported that compared to normal eyes, the reduction IUB was sustained and higher in vitrectomized eyes and independent of the baseline IUB. And we see that all these 3 studies included vitrectomized, non-vitrectomized eye. 2 studies included vitrectomized eyes. So we performed a meta-analysis on the effect of mannitol on vitrectomized eye by comparing the baseline and after treatment IUB at different multiple time points. And the first time point was 30 minutes, and at 30 minutes the IUB reduction was from baseline 19%, and this was statistically significant. IUB reduction after 30 minutes from giving the mannitol in vitrectomized eyes was 19% from the baseline, so it works in vitrectomized eyes. At 60 minutes, the IUB reduction effect was 16.7%. The IUB reduced after giving the mannitol in vitrectomized eyes. At 75 minutes, the reduction was 30.2%. So here is the starting point that the maximum reduction effect, more than 30% from the baseline IUP at 75 minutes. At 90 minutes, the reduction was 24.3, but again at 2 hours, it reached to 27.4 reduction from the baseline IUP. At 3 hours, the reduction was 30.8 from the baseline IUP. Also, at 4 hours, the reduction was 30% from the baseline IUP, and all of these results are statistically significant. So IUP was reduced in all multiple different time points from 30 minutes until 4 hours in vitrectomized eyes. And when we compare the effect of mannitol in vitrectomized versus non-vitrectomized eyes, there was no statistical significant change between the two groups, indicating that the effect of IUP and the effect of the mannitol on the IUP was similar in both the groups. There is no statistically significant change between the two groups. So you are giving mannitol in vitrectomized eyes like giving mannitol in non-vitrectomized eyes. So the discussion. This study meta-analysis was the first meta-analysis that compared the effect of IV mannitol on both groups, vitrectomized and non-vitrectomized eyes, and our findings suggest that mannitol is an effective agent for reducing IUP in both groups. So the main lesson, the main takeaway from this meta-analysis, that you can give mannitol in vitrectomized eyes, against the common belief between ophthalmologists or eye surgeons that mannitol doesn't work in vitrectomized eyes because the vitreous is already there is no vitreous to shrinkage or to dehydrate. However, as we said previously, that we have multiple mechanisms. The first mechanism is vitreous dehydration. The second mechanism is central mechanism by affecting the osmoreceptors. And third one is that combination between the two, between these both mechanisms. And also another important finding of our meta-analysis result, the timing. That we saw previously that the maximum effect of the mannitol was after 75 minutes. At 75 minutes time point interval, the IUP was reduced by 30.2%. So if you are going to do a surgery for a patient, silicone oil or vitrectomized globe with high IUP, if you want to give him mannitol preoperatively, it's better to plan that at least 75 minutes before the surgery. This is the importance of the timing. However, our meta-analysis faced multiple limitations. The first limitation, small number of studies, only 5 studies were included. Also, a lack of long-term follow-up data. The maximum time point was 4 hours. We don't have any data after 4 hours. Also, most of the studies were from India, China, Pakistan, so there was geographical concentration. This geographical concentration could restrict the generalization of our results across different patient demographics. So to conclude this lecture, mannitol is beneficial in reducing the IUP in vitrectomized eyes or silicone oil-filled eyes. So the main takeaway, you can give mannitol in vitrectomized / silicone oil filled eyes. This is the quote of the today for you all. Thank you for attention. Thank you for listening to this lecture.